at least once, after 18 years of age. And then if you have a borderline value, or if it needs to be monitored, it needs to be regularly checked up. And of course, you must have your blood cholesterol levels checked more than 18 years of age at least once. And of course, much more frequently if you have family history of heart disease or stroke. So essentially, we are looking at adequate, healthy fuel for the heart. Then we're looking at good exercise, cardiovascular exercise that's moving your heart. And of course, cessation of high risk factors such as stopping smoking. And if you add these three concepts with knowing your blood glucose levels and your blood pressure and your cholesterol, you can prevent the type of heart disease which I showed you in the first patient quite effectively, if I may add. And of course, we have many online tools which even people can use even without medical supervision. I think all you have to do is input your blood values, your gender and cholesterol levels and blood pressure values. And we have an ASCVD risk score by the American Heart Association, which tells you what is your 10-year risk of heart disease, of the kind of heart disease that I showed you in the first case example. And of course, this acts as a big motivation for individuals to sort of course correct in their, to perform certain course corrections in their lifestyle to have a healthy heart disease. So let's move on to our patient number 2. So this is again a 62-year-old gentleman who had a heart attack in 2014. And like the first patient which I showed you, this gentleman had an angioplasty in 2014. Now, importantly, if you look here, I've added a term called moderate LV systolic dysfunction. So this means that after an attack, his pumping efficiency of the heart had reduced to 35%. So that's something that's called ejection fraction, EF 35%. For a normal individual, it should be somewhere close to 60%. So this is had significant depression of 35%. So he was doing well. He had an angioplasty in 2014. He's had regular checkups. So in early 2016, he was gardening and he collapsed with a cardiac arrest. Luckily for him, he was resuscitated by a bystander and he was brought to the emergency room. So obviously, our first suspicion was whether he had an obstruction, a new obstruction in the blood vessels, but we did an angiogram and showed that the stent which had been placed in 2014 was okay. So what is the problem then? So why did he have a cardiac arrest? The answer is this: ejection fraction 35%. So the idea I'm trying to drive at here is, even if you've had a heart attack, even if you've had a successful angioplasty or a bypass surgery, if you have a reduced pumping efficiency of your heart, it's time to be careful, and you have to be careful for the remainder of the follow-up period, because regular follow-up intervals are required. You need to be on adequate medications to reduce your risk of a sudden cardiac death, or a potential cardiac arrest, like a patient like this. And the important thing I'm driving at is, if you have a reduced EF, you must be regular with your follow-up routines with your treating cardiologist, and you must be on the appropriate medications for the same. So what did we do for our patient here? Our patient had a large scar. So we did a cardiac MRI and it showed a large, if you follow my pointer, you can see there is a semilunar white density over here, which means this is a large scar in the heart. And this is the large scar which is responsible for a fatal heart rhythm issue in this patient, and he had a cardiac arrest. So we implanted something called an AICD, which is a special kind of pacemaker, which will prevent a further potentially fatal cardiac arrest for this patient. So my emphasis in this patient example is, even though you've had a successful procedure, even though you've had a heart attack in the remote past, it's always important to have a close follow-up with your treating cardiologist. Have appropriate investigations at the necessary intervals, and you need to be followed up longitudinally to have the best cardiac outcome. So symptom awareness and regular follow-up is key in this scenario. So let's have a look at our patient number 3. So the first 2 examples were of patients who had a heart attack. So essentially we were looking at patients with obstruction of the blood vessels in their heart. Now this is something different. So I'm going to switch gears a little bit from patient number 3 onwards. So this patient had a diagnosis of hypertrophic cardiomyopathy. As Shweta mentioned earlier, this is one of my research areas. So hypertrophic cardiomyopathy, to put it very simply, is the most commonest genetic disorder of the heart in which the walls of the heart become thicker and thicker without any specific reason. And it is the commonest reason of sudden cardiac death in young athletes. So young athletes, so it all started in the US when basketball players started to collapse and die on the basketball court with cardiac arrest. That's when the disease came into public prominence. So essentially, if you have hypertrophic cardiomyopathy, you must be careful at the level of exercise that you're performing. So our patient is a 46-year-old lady who was diagnosed with hypertrophic cardiomyopathy, and she's been under follow-up for quite some time. And she has, the aspect written in yellow text is the mutation. So I don't think we need to pay more attention to that at this point in time. It's enough to understand this patient is a patient of hypertrophic cardiomyopathy. So essentially the patient has an 18-year-old son and a 20-year-old daughter, and both of them had not been screened. This is hereditary disease. Both of them should have been screened, but for logistic purpose, for some reason or the other, we never got around to screening. Or rather the family never got around to bringing their children for screening. So essentially the 18-year-old son had an episode of unconsciousness while riding a bicycle one day, and it was not pursued further. And 4 months later, unfortunately, he climbs up 2 flights of stairs in his college. He was an engineering student, and he has a sudden cardiac death in class. He just collapses in front of everyone, and to the classmates' horror, they could not resuscitate him. And this was a tremendous tragedy in his family's lives. So the point I'm trying to drive here is hypertrophic cardiomyopathy is a very common genetically inherited heart disease. The essential point is, once you're diagnosed with this disease, or once a family member is diagnosed with this disease, it's important to screen every first-degree family member for the presence of this disease. And it's very easy to do so. All that you need to do is an ECG and an echo of a patient, of a relative of a patient with hypertrophic cardiomyopathy, to find out whether the sibling or the parent or any other relatives are affected with this disease. So probably looking back, if the screening had been done, and if we had recognized that this son had evidence of heart disease, hypertrophic cardiomyopathies, potentially we had a window where we could have performed some measure of counseling or precaution against heavy exercise, or we could have risk stratified him so that we could have avoided a potential sudden cardiac death in a young individual. So as you can see, it's the commonest inherited heart disease. This is the point which I alluded to. And on the left-hand side, this is a cross-section. This is actually a autopsy sample, a specimen of a patient who had died from hypertrophic cardiomyopathy. And as you can see, the walls of the heart are substantially thick in any direction that you go. And this is the left ventricle. So it's an abnormal thickening of the heart. Sudden cardiac death can sometimes, unfortunately, be the first manifestation. And as I mentioned earlier, the potential solution is to risk stratify every patient and their relatives. It's very important, and their relatives, for evidence of this disease. So are there other diseases which can cause sudden cardiac deaths apart from the heart attacks which can happen in the first 2 patients? Yes. So we have certain elements of heart disease which can affect the electrical systems of the heart, such as long QT, Brugada, ARVD. So essentially, I'm not going into the details of these disorders per se, but it's important to understand that there are some genetic disorders of the heart which can lead to sudden cardiac death in young individuals. So if you have an episode, or if somebody comes with a history of unconsciousness, abruptly fell down unconscious, it's important to thoroughly evaluate for disorders such as hypertrophic cardiomyopathy and these kind of inherited genetic disorders. So let's come now to our second last patient, who's patient number 4. So this was one of our residents at our institution. So you can notice that the age, it's a very young patient, 26 years of age. And interestingly, he has no diabetes, no hypertension, normal cholesterol levels, doesn't smoke, doesn't consume alcohol on a regular basis, and he presented with a heart attack. Now, that's very surprising, isn't it? So because till now, we've seen patients who come with a heart attack with risk factors such as diabetes, hypertension, and high cholesterol levels. And this is an individual who is a medical student at our institute who had no risk factors such as these. So he had a heart attack. He had a massive heart attack. We had to take him into the cath lab for an emergency angiogram, and we found that one of the blood vessels was blocked, and we needed to do an emergency angioplasty for him as well. Now, the question is, why did it happen to him? He didn't have any risk factors, quite young age, no diabetes, no hypertension, nothing at all. Not everything can be explained by the traditional risk factors of hypertension, diabetes, and cholesterol. So it's important to understand that there are certain subsets and in the population where you might have people, young individuals, coming with a heart attack, but not having the usual risk factors. And in this situation, the answer is potentially genetic, family history. And interestingly, it turned out that there were many individuals in this particular student's family who had a heart attack in the age group between 30 and 40 years of age. So even though you don't have any of these risk factors, family history is essentially very important. And it's important not only for the treatment of this particular patient, it's also important to understand the risk level of the relatives of this particular patient, and they need to be looked at even closer to prevent an event which this particular patient had. And that's exactly what we did. And we found that this patient had a genetic anomaly or variant which predisposes them to early heart attacks at young ages. And again, none of the relatives who had an event had evidence of diabetes, hypertension, or normal cholesterol level. So not everything is always explained by traditional factors. Sometimes you have to think outside the box when you're presented with an unusual scenario like this. So with that, let me come to patient number 5. So again, I'm going to switch gears a bit, and we're going to stick to a younger patient this time. So this is a 30-year-old male who's a software engineer by occupation. And the patient had no risk factors for heart disease, no history of heart disease prior to this, and no history of heart disease in the family. Unfortunately, this particular gentleman was diagnosed with leukemia, and in consultation with our oncology division, completed 3 to 4 cycles of chemotherapy. So the problem was he was admitted with heart failure. So one might ask the question, so what's heart failure got to do with the clinical background of this patient? The answer is it has everything to do with the clinical background of this patient, because when a patient with a history of chemotherapy gets admitted to our cardiovascular division with a cardiac issue, there is this growing specialty called cardio-oncology. So the specialty of cardio-oncology essentially means that patients who take chemotherapy agents to survive their cancer can sometimes have diseases which are associated with the heart. And these are essentially brought on by the medications used for cancer therapy. So the question is, can you avoid giving these agents? No, because it's essential for them to survive their cancer. But what we can do is to ensure that we can give them adequate cardiac medications so that they don't end up with heart failure when they take chemotherapy. So essentially, a diagnosis in this patient was chemotherapy-induced heart failure. And you can see that the ejection fraction, which I showed you earlier, is a marker of the pumping efficiency of the heart, was very, very low, 20%. One needs a normal of 60%. So this is the exciting field of cardio-oncology. And this is something which I think all of us should be aware of. There are hundreds of thousands of cancer patients who take chemotherapy for their cancer so that they can have the best treatment outcomes for their cancer. It's not enough that they survive their cancer. It is mandatory that they should survive it with quality cardiovascular health. So patients should survive their battles against cancer, but they should not succumb to heart disease. And that's something which has been happening for quite some time. And the prime example of that is the patient which I showed you. So early evaluation and preventive medications are the potential solutions. So cancer patients must have their cardiovascular health closely tracked. At our institute, we have a division of Cardio-Oncology, which is one of the first divisions of Cardio-Oncology in the country. And we strongly believe that we've been able to make a huge difference in the cardiovascular health of patients who've been taking chemotherapy to, on one side, to optimize their survival from cancer, and second, to make sure the cardiovascular health is not compromised by chemotherapy. And with this, we come to the last patient for today. And this is a very interesting patient, and I assure you this is completely different from what we've seen in the previous 5 patient examples. So this is a young patient, no risk factors for heart disease, no history of heart disease prior to this or in the family. And interestingly, this is a triathlon enthusiast. He enjoys entering every Ironman competition in the vicinity or otherwise. In short, he lives to test his endurance at these endurance events. And of course, for such an individual, a very intense aerobic workout is part of the daily routine. Now, interestingly, or unfortunately, I would say, he was admitted with heart failure and an abnormal heart rhythm. Now, you might think this doesn't make sense, right? You have a very young man who's a triathlon enthusiast and who has aerobic workouts every single day, intensive exercise, and the kind of events that he enters are of the extreme endurance kind. So you'll be surprised to know that the diagnosis here is surprisingly, and I would say unfortunately, it is excessive exercise-induced heart remodeling. Now, before I go to the next slide and explain this entity, I would like to throw a caveat out there. This does not mean that you should not exercise, and that's not the message which I want you to take away from this patient example. The message, I think, which is very important here is exercise is extremely important for the cardiovascular health, for the health of the heart. The problem happens is when you really chase it in a very intensive, excessive manner. So according to our heart guidelines, Cardiovascular Society guidelines, 150 minutes of exercise every week of moderate intensity is the actual healthy sweet spot of exercise. But as in this case, it's a problem because he actually presented with heart failure and abnormal heart rhythms because of the extreme intensity with which he pursued his exercise routine. So there is something called exercise-induced remodeling of the heart. And you can see that although we will not go into the mechanisms here, you can see that extreme exercise efforts can sometimes lead to certain immediate effects of acute strain for the heart. And sometimes if the person maintains this intensive regimen for quite some time, it can lead to sort of fibrosis or scarring in the heart and can lead to certain deleterious or adverse long-term effects. So it's always important that it's always important to have systematic, well-monitored training as the athletes are. The athletes are always under professional supervision. So if you take it to the other extreme, in the long term, you may have a situation where it might adversely impact cardiovascular health. And this is the one picture which I want you to take away from this patient example is on the y-axis, you have all-cause mortality, or in the sense, adverse cardiac events. And on the x-axis, you have the amount of exercise. So starting from sedentary, which we know is not good, if you keep increasing your level of exercise as you come further down, this appears to be the optimal amount of exercise where you have optimum cardiovascular health. But from here onwards, if you push it further to extreme events, extreme endurance long-term, you start to see that the curve, that is the adverse events which started to dip, is now slowly starting to go up. So essentially the simple message from this slide is there is an optimum amount of everything. And I think there is great wisdom in the old saying that too much of anything can be very much a problem. So this is my last slide. So essentially, from all the 6 examples that you have seen from the previous slides, it's always important to understand certain concepts in cardiovascular care. What is primary prevention? So primary prevention is a situation where, let's say you are a diabetic or hypertensive, but you don't have heart disease yet. It's very important to control your diabetes and hypertension as much as possible so that you don't end up with heart disease. That's called primary prevention. You're preventing it even before it has happened. So what's secondary prevention? Secondary prevention is you have established heart disease, but you want to avoid the complications of heart disease. So essentially, you need to have regular follow-up with your treating cardiologist, be regular with your medications, and you have to have a healthy lifestyle planned out in consultation with your dietitian, with your exercise therapist, and your treating cardiovascular physician. Yes, we do have risk prediction models for all age groups and for all of the diseases which I just showed you. And some of the risk prediction models are actually performing very well. And it's important to look at these risk prediction models during your follow-up visits with your cardiovascular physician. And of course, now there are shifts in cardiovascular care. For example, an unpredictable shift has happened in the last year itself, where we are right now in the middle of a raging pandemic, such as COVID-19. And it's important to understand that patients with severe heart disease, let's say a patient with reduced pumping efficiency of the heart, the patient has patient has had a heart attack before, patient has heart failure. These are the type of patients who should be careful in today's raging pandemic, and they should not be afraid to reach out to cardiovascular physicians, either as a physical consult. And as Shweta and Japneet earlier said, now we are in the digital age, where I think a cardiovascular consult or a follow-up visit is just merely a click away.